All right, inflammatory bowel disease. It's amazing to me how many things that we know are autoimmune linked. We have multiple sclerosis, rheumatoid arthritis. It's just like there's just more and more and more things. This is one, when I was in school, this was considered stress-related or inherited, and now we know that it's autoimmune. So it's one of those diseases that's gotten a lot more attention in recent years than it used to have. It's different than irritable bowel disease. Many of our patients have irritable bowel disease, exacerbations of constipation and diarrhea brought on by stress. Sometimes small structural changes in the bowel, but usually it's emotional, cognitive in origin. This is different. This is physiologic and autoimmune. Okay? So, chronic inflammatory bowel disease, chronic inflammation of the digestive tract, mostly the bowels, but it could affect esophagus, stomach, anywhere. Okay? The two major diseases in this group are ulcerative colitis and Crohn's disease. And there's tons of commercials out there right now about these diseases because we figured out the MABs and FABs help them. So now we've got commercials everywhere. Okay. Both of them, severe diarrhea, fatigue, weight loss because of severe diarrhea. Some of these patients have up to 20 diarrhea stools a day. I can't imagine how hard it would be to function with 20 diarrheal stools a day. Should have made you get me one too. That's going to be my new standard. You're coming in late to class because you went to Starbucks. You're going to have to bring me one with you. I'm teasing. I'm joking. Anyway, so I am teasing. I can walk over and get my own Starbucks.
If they spilled your coffee, we would have done that.
Should I go back and get it again? I love it. All right. So, in terms of, think what 20 stools a day does to you. Fluids, electrolytes, acid-base balance, skin, emotions, role, relationships, work, school, whatever, yeah. I can't imagine what living with this disease is like. These diseases, okay. Because dehydration and nutritional loss can be life-threatening, these diseases can ultimately cause life-threatening problems. Often start in the teen and young adult years. Can you imagine a 16-year-old having to deal with this? How hard at a time when everything in your world is upside down and your self-esteem's all over the board anyway, to be dealing with something like Crohn's or ulcerative colitis. What a surprise. It's autoimmune and it exhibits in the form of exacerbations and remissions. Pretty amazing. I don't know anything else that does that. Who's the biggest ethnic risk? Caucasians and Ashkenazi Jews. Middle European heritage. Yes, it is. Yes, it is very specific. Okay, ulcerative colitis. 4 to 20 stools a day with blood and mucus in them. Right? So every hour. What about sleep? Yeah, we're not talking about easy. This is tough stuff. And we said food and electrolyte loss. They have bad abdominal cramping that's relieved by defecation. So you guys have probably had diarrhea based on something you ate or a viral illness. And you guys may remember cramping followed by defecation is better for a minute, and the cramping starts up again, right? This is important with this disease. In the bowel, it affects the mucosa and the submucosa only. It does not enter the bowel wall. The disease does not affect the musculature in the bowel. It only affects the mucosa and the submucosa. Ulcerative colitis is continuous colitis. Okay? Its earliest inflammation starts in the rectum. And its inflammation is continuous. So it starts in the rectum, goes to the colon, goes up the sigmoid colon, goes up the ascending colon, goes across the splenic twist over here, goes across the transverse colon, hits the hepatic loop, then goes to the descending colon, and it's continuous. As the disease progresses, more and more of the inflammatory problem is extended upward, but it's continuous. So the inflammation is continuous through all that tissue. Make sense? That's an important concept in a minute. Okay? Continuous colitis. So complications of this disease with your 20 stools a day and inflammation all throughout your gut. Bowel perforation, hemorrhage, bowel hemorrhage if you're having 20 stools a day with blood and mucus in them, blood loss, hemorrhage, and if you perforate, that's probably going to hemorrhage too, right? If you rip your bowel apart, likely to bleed. High cancer risk. Colorectal cancer is tightly linked to patients who have inflammatory conditions in the colon. Familial polypitis and ulcerative colitis both lead to high cancer risk, and they're both problems in the bowel. And then a toxic megacolon, and that's a whole different complication where your bowel gets wildly inflamed and enlarged, and ultimately can lead to perforation. And stuff. I don't know how your bowels are like. The stuff in my bowels is pretty toxic, and I'm not eating it. Although some people get stool replacements, right? I know they don't eat them though; they get it by Anna. So, in your peritoneal space, which is where your intestines live, that's sterile, right? Your peritoneum is sterile. So if you got stuff leaking out of your bowel, you're going to be high risk for peritonitis, right? Inflammatory problems of the bowel. All right, primarily by duplication of the rectum. Okay, so bowel perforation, hemorrhage, cancerous, toxic megacolon. So what nutritional problems do they have? Hypoalbuminemia. What is albumin? It's a protein. It's a protein. What do proteins do in our bloodstream? Why do we need them? They build tissue. They build cells. They also hold fluid where it's supposed to be. It's osmotic pressure, right? Exactly. That's an important concept this semester and next. One of the things you'll see is people have edema. I think we even talked with RA and MS about they get edema in their periphery, right? So people that have edema, pulmonary edema, peritoneal fluid, pleural fluid, peripheral edema. That's fluids that have third spaced or left the vascular space and gone to places they don't belong, right? One of the things we always want to do is bring that fluid back to the bloodstream. It helps with the patient's pain and body function. It also helps with blood pressure and dehydration that might be caused, right? So we want to keep fluids in the bloodstream so our brain and all our other organs can get great perfusion. Hypoalbuminemia, if you have that, the fluids aren't staying in your blood vessel. They're going to go, oh, look, it's got a higher osmolality out there. I'm going over there. So it goes to your subcutaneous space and things start swelling, right? So one of the things you'll see in clinical practice in advanced med surg is when patients have edema of whatever, and their albumin levels are a little low, protein levels are a little low, we think they're malnourished, they're having imbalance of some sort, we will give them IV albumin. And IV albumin will build the colloidal pressure and suck all those fluids back where they belong. Make sense? That may be old hat. You probably learned that in level 2, but I always like to jump through that hoop again in level 3 and 4 because you're going to see it in practice. Not so much in OB, but in level 4. But you'll know that. You'll be so far ahead of the game. When they ask you that in level 4, you know that.
You explain it so much better, though.
I got this. It's no problem. Okay. So if you are having 20 stools a day, it's likely you're not absorbing your nutrients, so you're going to have weight loss, anemia, malnutrition, weight loss twice. I guess you're really losing weight. And because it's inflammatory, it can lead to inflammation of your joints as well. All right. Why do we have it? We don't know. We do know that it's a surprise. It's autoimmune. We don't know what causes it. But we know it's got familial links. Twin studies, family studies have shown it's much higher likelihood if you've got somebody else in your family with it. We do believe it's autoimmune. All the research is there. Peak incidence, look at those ages, 15, young adults. And then again, when you get to middle age, it might rear its ugly head again. You're going to have exacerbation remissions all along. For initial episode, teens and young adults, and then very few people in their 40s have an initial episode, but when they get up there in their 50s, 60s, and 70s, they might then develop inflammatory bowel disease, ulcerative colitis. right? Remissions and exacerbations. Flares. One of the big deal with this is the patients have to figure out what causes their flares. Because this is one that's a little bit more controllable through diet and stress reduction. RA, lupus, MS, yes, they're controllable, but this one, diet really makes a huge difference on. So we help them understand, do logs, and track symptoms to figure out what causes their flares. So stress, dairy, so milk, right? Fried foods, spicy foods, hot, extremely hot foods, not just spicy hot, but I ate something really, really hot, temperature. And intestinal infections, that would make sense. Intestinal infections could give you diarrhea and start the inflammatory process. But nutrition. So if you're going for French fries and a milkshake and you have ulcerative colitis, this time tomorrow you might resent that decision, or might wish you hadn't. Okay, so what are the systemic effects of inflammatory bowel disease? Ankylosis, that's spinal problems, and arthritis. That's both bones, basically. Erythema nodosum. What does the word erythema mean? Aphthous ulcers. What's an aphthous ulcer? Anybody had one? It's a mouth ulcer. It's a mouth ulcer. Those stress ulcers you get in your mouth, they heal pretty quickly. They come up when they have a flare. Sad. That doesn't mean it just because you have them doesn't mean you have ulcerative colitis.
No, it's a canker sore.
Okay, there's a canker sore and a chancre sore, right? Chancres go with syphilis, cankers go with aphthous ulcers. So you can have a canker sore. You can have a chancre sore, but it's not caused from this. We're going to do that later this semester too. But a canker sore, yeah, basically those little ulcers.
It's just what causes it.
Stress related most of the time. Autoimmune disease can play them, huh?
No, when we were starting this with ulcerative colitis, I thought you were saying, I remember you saying that it was continuous, there's not a
Continuous
relapse.
colitis.
But then on the pathology one it says remissions and exacerbations.
Exacerbations. The inflammation comes and goes. When it comes and goes, it's continuous. When it comes, it's continuous.
How is that different from like the autoimmune stuff having a flare? Like,
It is. It's a flare. That's what
okay.
it is. It's a flare.
Because I'm thinking like,
It's continuous colitis. I mean, all the tissue is continuous.
Okay.
You don't have inflammation over here and inflammation over here. You have inflammation in a continuous line all the way up the gut, depending on how far up that disease has risen on you. The
I
initial
was thinking
symptoms
like
at
a
15 going to start in the rectum.
okay. I was thinking like a select all question.
Oh, got it. Yeah, she's thinking ahead to the test. Okay, you can thank her when you get that question right. All right. I don't think we'll have that question. But whatever. Conjunctivitis. What's conjunctivitis? Where's your conjunctivitis? This. Where's your cholelithiasis?
In your gallbladder.
Gallbladder. Itis. Lithiasis is what? Stones. Cholecystitis, inflammation in your gallbladder. Cholelithiasis, stones in your gallbladder. All stones. Cholangitis, also gallbladder inflammation. Huh?
I'm reading.
Okay. I'm like, huh? Why would they get osteoporosis, do you think?
They don't get malnutrition.
Yeah, their malnutrition is largely connected to that. And then, interesting enough, the inflammatory process, especially if it gets in your blood vessels, we did vasculitis, where I said, what does that put you at risk for? It puts you at risk for emboli, because everywhere you have inflammation in blood vessels, platelets are going to stick, microemboli are going to form, and if you get microemboli, then you get pulmonary embolus, stroke, right? All those things are bad. Myocardial infarction. All right, so diagnostically, what do we see in lab? Person comes in, I've had 20 stools this week, I'm 15, my dad had ulcerative colitis, I think I'm in trouble. Doc says, let's draw some lab. Your H&H is going to be low, your white cells will be normal to high. Inflammatory, it's a response, right? C-reactive protein, it's an inflammatory marker, it's up. ESR, inflammatory marker, it's up. Easy to figure out. Sodium, low. Potassium, low. Chloride, low. And albumin, low. They're pooping it all out with their fluids. They're not retaining it in their bloodstream, so their electrolytes get all whomped, right? What does hyponatremia look like? This is level 2, right?
Yeah.
I know. And guess what? It comes back to haunt you. Every semester it's going to haunt you. Hyponatremia. You probably, often it's a combined fluid loss because of the sodium over the fluid. So it might be hypovolemia. But can you lose sodium and have normal volemia?
Yes.
So when you think hyponatremia, think fatigue, tired, lowered level of consciousness, depressed affect, depressed movement, all that stuff. Potassium. Potassium can be high and low. Low potassium, we always go hard, right? But potassium's the sodium-potassium pump. What's that for? Muscle contraction and relaxation. So it can, and nerve conduction. So it can affect muscle strength and muscle fatigue if you're low in potassium, right? Because you can't restore things the way you should. And yeah, we always think potassium heart, because high and low potassium heart. We always replace our potassiums quick because of heart, because you die from heart, not so much from my leg muscles. We don't really study a lot about low chloride. It's not what I care about. Studying potassium, those are big deals. And then through albumin, we already talked about the edema and the fluid shifts. Other things that we're going to do. Now we're going to schedule you for a colonoscopy. The doctor's going to go in with a garden hose that has a camera on the end. He's going to start at the rectum and look up. And he's going to look all the way through the colon, all the way around to where the small bowel attaches to it. And he's going to say, oh, look, continuous inflammation. Or, in Crohn's, it might be different pattern. And so after we get diagnostic, then every 10 years they should have one. If they're having a lot of flares or change in status, we might have another one additionally. Remember, they're high risk for cancer. So we want to do the colonoscopies to keep monitoring for the cancer piece. Like if I'm monitoring cancer in my bowel, one of the things I can do is like with those occult blood tests in my stool to see if I have blood. Could they measure blood in their stool to see if they have cancer? No. They have blood mucus in their stools a lot, so it's not going to be definitive. So the colonoscopy is going to they have to differentiate and diagnose. A CT scan can also help confirm, and then a barium enema. You know what an enema is? What's barium? It's a contrast dye, right? So we give that enema, it's like chalk through the enema. They illuminate on the radiograph, on the x-ray, and we can see the inflammatory of the bowel wall, the structure of the bowel. What's important about a barium enema afterwards?
Flush it?
Yes. Yeah.
Okay. Flush it, and what did you say? I heard I'm old.
Doesn't it like stay in the tract?
Yes.
Yeah.
He said flush it, like, and not just flush, but flush it out.
Yeah, flush it out.
It's like chalk, and so for the next 2 days, your stools are going to be clay-colored. Now, that's not bright red East Texas clay, like we have in Texas. You say clay-colored to people who live in Texas, they're like, oh, bright red. Yeah, it's clay-colored like gray or yellowy gray. Okay, and you're like, that's not clay. Well, it is if you're doing modeling clay in art. Okay. Well, I mean, that's a real cultural thing. I've had students get questions wrong because they didn't answer clay colored stool, and they're like, no, clay's red. And we were going, okay, yeah, in Texas it is, so we had to give it, so whatever. So I'm always very clear, we're not talking about East Texas clay. We're talking about gray clay, right? Gray. You know, stool is supposed to be brown. It's like mixing it with chalk. So it's yellow and gray. The other thing is it can turn to concrete in there, right? So, I mean, not literally, but it hardens up and can impact your bowel thoroughly. And so if they have not cleared and got normal colored stool bath or haven't had a bowel movement in 72 hours, they need to go immediately to their provider, and they will most likely at 72 hours they'll provide a laxative. But if that doesn't work, then they're going to, you might have to have surgery. It's happened. People had to have surgery to remove the barium because they didn't drink a lot of fluids, flush the bowels out, and eliminate effectively. So barium enema will differentiate ulcerative colitis from Crohn's. So will a colonoscopy. We'll talk about that in a minute. All right. Oh, here, there's a picture. You want to see a movie of ulcerative colitis right before lunch? Let's look at bowel pictures. Let's do this. We're nurses. We can handle this. Get your volumes turned up. Can you hear it? No. Well, you can see it.
Does it make noise?
It does. I want to exit. I want to turn my volume up. There it is. Oh, a musical colonoscopy.
I've seen this one before.
Look at all that information. And you see how it's continuous all the way up? Inflammation. That looks like it hurts, right?
Yes, it does. Looks like a colonoscopy would hurt.
Well, okay. You are under anesthesia during a colonoscopy for a very good reason. You are asleep because they were putting a garden hose with a camera on it through your bowel and running it all the way through. You're asleep for a reason. And how important now do you think it is to do a good bowel prep? That mag citrate or go lightly or whatever we're giving is very important to eliminate all the stool because you couldn't see the inflammation if they're pooping on it. Now I think we found better stuff, right? Oh, he's taking a biopsy. Let's biopsy this. See if he's got cancer. I see a
So dramatic.
It's a musical colonoscopy. That's actually pretty cool, all right, that we can do this. And then now that's going to heal. Is he going to have blood in their stool for the next day or two while it heals? Of course. Oh, look, a plethora of forms.
A good patient
And the
teaching
spring finale.
tell them did not expect to go back to work, which would think is common sense.
I'm sorry, what?
A good patient teaching would be to tell them to not expect to go back to work that day, which you think is common sense.
But it
But
may
I've
not
heard
be.
of people.
The problem is they were under anesthesia. So you shouldn't drive or do anything you have to make a decision. You shouldn't drive or do anything that makes the decision. Yes, you're not allowed to drive when you drive away from the clinic. But that does not mean that somebody goes, okay, I got driven out from the clinic, I'm going to Walmart now. Right? And they get in their car and drive themselves to Walmart. Or they go to the bank and buy a house hours after anesthesia. Never a good idea to sign your will, make financial decisions, sign divorce papers, anything like that while you're under the effects of anesthesia. Just saying. Even propose. I wouldn't do that right after anesthesia. Now, who knows who you has to marry? Okay, so what's your patient going to talk about? I have bad abdominal pain and increased bowel sounds. You're having 20 stools a day. Yes, your bowels are moving. And so, bowel sounds. What's normal? Okay, 5 to 15 seconds in all 4 quadrants. Okay. Hypoactive. Less than 5. And actually, what about absent? How long do you have to listen before you can actually call it absent? 5 minutes. Somebody taught you well. Good. Okay. Who? Professor Otis taught you your assessment. I love it. Okay. Frequent stools, diarrhea, 20 stools a day. I consider that frequent. Normal bowel pattern. What is normal bowel pattern?
Depends on the patient.
Depends on the patient. What range do we kind of think of? Once a day, maybe twice a day. Sometimes every other day. Most people go at least every other day. Rare to go 3 days, but occasionally I find a patient who's like, yeah, I pushed the 3 days. But we know. Maybe not by choice. But most patients, it's every day, every other day. Okay. Fever, weight loss, B12. Let's talk B12 for a minute. B12 is an important vitamin. It's important for your neurologic development, neurologic intactness. It's important for cognition and energy, the formation of red cells, and it prevents neuropathies. It's neuroprotective. So, if you have B12 that you take in, how do we get B12 into our bloodstream from our gut? You had an aha moment.
It's water-based, so
It is water-based.
past your stomach.
Your stomach makes something called intrinsic factor. In your stomach you've got the greater curvature and the lesser curvature, and down here in the pylorus, and it goes to the small intestines, right? Down there at the base of your stomach you make intrinsic factor. intrinsic factor must be present with the B12 to absorb through your terminal ileum. The ileum is the last part of the small bowel, right? So you have to have an intact last part of your small bowel, and you have to have B12 in your diet, and you have to have intrinsic factor present with it. So people that age don't make enough intrinsic factor. The elderly are really commonly low in B12. People that are vitamin suppressed, have malnutrition, can't absorb their nutrients. If you have inflammation in your terminal ileum, you're not absorbing your B12. So you can have neurologic problems, cognition problems, energy problems, anemia problems, right? B12 is an important thing. While we're talking about B12, I have to get on my soapbox or my rabbit trail or wherever I'm going. But old people lose the ability to make as much intrinsic factor. They can absorb B12 if they have intrinsic factor, but they don't make it as freely. Young people make that much better than old people. If I'm older, oral B12 may not be the best route, right? Because so there's other ways we can take B12. You can take it by injection. I don't like that. Ew, who wants to do an injection? But you can, and we do a lot in the elderly. Like in long-term care, you'll find people that are on weekly B12 injections. Cyclocobalamin is B12. That's a long, fancy name for B12. It can be given sublingually, intrabuccally. It can be given by nasal spray because it bypasses the stomach absorption, right? So for the elderly, any of those other routes. When you do anemia, sometime next semester, I think, you've done iron deficiency anemia, but there's a whole bunch of anemias. B12 deficiency anemia is pernicious anemia, and its cause is a lack of intrinsic factor. So let's talk about these people that are doing weight loss surgeries.
Losing the part of the stomach.
You might, part of the stomach area that's cut out. A lot of them, we do bypasses. We're bypassing the lower part of the stomach and the duodenum, or we're taking it out, or bypassing it. And so you might be losing vitamin absorption with those too. So that's with those patients, you have to watch that same thing, right? I know that's not what I'm talking about, but I can't help trying to make linkages. It helps me be a better nurse to talk about, and I hope it helps you be a better nurse.
The B12 though, it acts fast. I mean,
For energy, it does. 5-hour energies, they've got like 17 million grams of
but
B12,
I mean,
right?
you can
So it's
see
probably the caffeine that helps it.
resulting is fast.
Oh, yeah. Results happen quickly, yeah. Yeah, you can see it. The absorption and the metabolism of it is not hours in blood cell development, but days. B12 in nursing school, is that what you're saying? Must be outside. Okay, I thought my mic was in here. Okay. So other things we treat ulcerative colitis with. Aminosalicylate. Aspirin type products. Aspirin type products. They're COX inhibitors, cyclooxygenase, COX-2 inhibitors. A lot of anti-inflammatories fall into that category, like aspirin. So they remove free radicals. Woo! Free radicals, all those extra oxygens, they increase inflammation. You know what that is. Sulfasalazine. I think we did that drug somewhere. Anti-inflammatory. It's a sulfonamide, so we have
A diabetic nutrition.
and sulfa allergy contraindications, right? So abdominal pain, agranulocytosis, an absence of granulocytes. Granulocytes are white cells, right? So low white counts. Aplastic anemia, I mentioned this in our little farm thing. That's the absence of all cells. Platelets, red cells, white cells, and platelets will all diminish. Pancytopenia. Crystalluria, what's that? Crystal formation in urine. So that can cause stones too. Hepatocellular necrosis. Anything that kills my liver gives me cause to worry, right? I like my liver. I'm attached. Paresthesias. Numbness, tingling, shooting pains in your extremities. Thrombocytopenia, those little platelets. I'm just a little redundant, but what the heck, I have to point them out. So take it with meals, swallow it whole, don't chew it, right? Drink a whole glass of water. You know, just 8 glasses of water a day. Drink a lot of fluids. You know you need to drink more water with your pills, right? Because the more fluid, the quicker they break down and absorb and get in your body. If they start having a rash, difficulty breathing, they need to tell somebody. Rashes and difficulty breathing, we're going to talk about in a minute under anaphylaxis. So we'll defer that short conference. But they cause photosensitivity, so sun exposure is a problem. And if they have sulfur or sulfonamide allergies, you really don't give it to somebody who's allergic to it. That's good. Mesalamine, another anti-inflammatory that's better tolerated for some people. Flu-like symptoms, but still a lot of the same stuff. I wouldn't get too caught up about it. There's a reason sulfasalazine was in your one answer. Corticosteroids. I don't know if we've talked about these yet today, but I think you're going to see some things that are repetitive here. They suppress the immune response to and prostaglandins, prednisolone, corticosteroid is a corticosteroid. If somebody has just rectal symptoms of inflammatory bowel disease, just the rectal symptoms of ulcerative colitis, they make steroid creams. You can just spread on your rectum. It'll immediately treat the inflammation, right, if it hasn't gone far. Now, tell a 15-year-old girl to spread a cream on her rectum, you might have a whole different conversation going on, right? So we've got some developmental issues we're dealing with, right? If they're on steroids, taper them off. You know about the side effects. They interact with other stuff. Take them in the morning to minimize adrenal suppression. They're going to keep you up all night anyway. Immune modulating agents. These are immune suppressors, full-on immune suppressors. Azathioprine, I've mentioned a couple times, Imuran. I've mentioned that drug in MS. I mentioned it in lupus. I think it was in the RA slides, and I know it's here because I'm looking at it. Azathioprine, that's a common anti-immune drug. You need to be aware of that drug. But again, it's not going to work overnight. You have to stay on it for a couple months to have maximum benefits. So the patients started on medicine and they have symptoms for 2 more weeks. They're thinking this drug's not working, right? So they're calling the doctor, they're stopping taking it, they have side effects, but it's still not working. You have to say, no, stay on it a little longer, it'll stabilize, it'll get better. Okay? But they're really high risk for infection when they're on it. So report rash, joint pain, infection, fever. All right. Then anti-diarrheal agents. Give me the name of one. Imodium. Lolol.
Hyoscyamine. Like an anti-diarrheal stuff.
I'm just not familiar with the generic name. That's okay. It doesn't mean it's not real. Kaopectate, right? The kaolin drugs. They're all anti-diarrheals, and anything that's going to slow up those 20 stools a day can be very effective. Take the dairy out of your life and increase the fiber in your life. Okay, and then we're the MABs and FABs, and we did infliximab last week, so you know all about that. But the opportunistic infection, secondary infection risk is a problem. And then antibiotics, specifically Flagyl, very, very commonly used with this particular disease. So, and they're taking it not like, I'm taking it for 7 days for an acute infection. They take it long term for bowel protection. It works, hopefully, with these patients. But it can cause peripheral neuropathies long term. And they're not absorbing their B12, which causes peripheral neuropathy, so we just have to be very aware of that. All right, surgical management. Not every inflammatory bowel problem can be treated with surgery, but ulcerative colitis, by its nature, is continuous. It must start in the rectum and move progressively up. So the patient's symptoms are bad enough, and they're bothered enough by it, and they're ready for surgery. We can do surgery to remove everything below that's got the inflammatory problem, do a colostomy. Ahmed doesn't like that idea. I'm seeing some body language here. So we can do some type of ileal pouch, and then anastomosis. We can take all the lower bowel out and take up here where the small bowel is and attach it to an artificial rectum that we make. We can make a J pouch and create a rectum. They can stool from there instead of through a pouch. All very good. I'll show you pictures in a minute.
A few people I know that have had just resections where they just took
Take out a piece.
out.
But that's not so much for ulcerative colitis. They just take everything. Yeah, Crohn's. And Crohn's, it doesn't always get treated well like
Yeah.
that. That's not the best treatment in the world for Crohn's, but it can be helpful. Okay, so for the step, usually these kinds of things are done in 2 steps. First you take out the colon, most of the rectum, you leave the anus and the anal sphincter, because I gotta have something to open and constrict. Remember, it starts in the rectum, didn't always start on the anus sphincter. And then we create an internal pouch with the bowel that's remaining with the stuff above it. Okay? We put a temporary ileostomy on for all of this to heal. And then 3 to 6 months later, 1 to 2 months, 3 months is good. The last patient I had for this had it 3 months later. They come in and they close the ileostomy. They've done a temporary ileostomy, which means it was a loop. So we just cut a hole in the ileum, put it back, it came out into the abdomen, we cut a hole here, put a pouch over it, the rest of it goes back through. All the stool comes out, doesn't transfer down, and it allows the bowel to rest. When we're ready to close it, we just close up that little hole, open up the little incision here, put everything back in where it belongs. You know, I giggle when I have. And then close it all back up. And then they don't have a pouch anymore, they just have a scar. Right? Okay, so then we close it. And then if they don't do a J pouch or an S pouch or something like that, we can do a permanent stoma and permanently let things leave through the abdomen. Yes?
She asked, can they do a transplant?
A bowel transplant?
Like they hold.
I don't know. We do intestinal transplants. I don't know if this is one of the reasons we do it or not. We do them. You can donate intestine as a cadaver donor, or even living, you can give a piece of intestine. You can't give all of it, you need yours. But we can give pieces of it, or in a cadaver donor, so you can take chunks of it, yeah. I mean, I don't know. I've not read about that. It's a great question. I would think they probably could. With this disease, I think they could.
I have a question too. So removing, since the it's an autoimmune disease, which means is it systemic?
It has some
This isn't going to cure it, right?
This will cure the GI symptoms.
Okay.
This disease has some secondary symptoms, but most of their symptoms are digestive. But it won't cure the arthritis that came from it.
Okay. Well, is it so? Once they remove that part of the colon, is that person still at risk for ulcerative colitis?
If we've removed all the disease portion, they're not at risk for ulcerative colitis anymore, and they're not at risk for colon cancer anymore, other than they're taking immune suppressants, which put you at risk for every other cancer.
But you kept saying that it's continuous, keep
Yeah, that's
going
what I
up
was-
and up
Right.
and
So
up.
if we remove it, we have to remove everything below the inflammation.
So it never can
And
start
it
higher?
stops. It stops it, and
Okay.
it won't
Okay.
progress.
So it never can start higher?
It won't start higher. It won't reoccur higher. We cut it out and we stop it where it was, and it does not come back in the upper part of the bowel, which is very cool. It's like, I have ulcerative colitis into my rectum. I'm having surgery today. I'm not letting this go any further.
That would make sense.
But you think about it, a lot of people don't want J pouches and things like that. Because even if you take out your rectum, you have to have some kind of device temporarily, and then long term, you've got to have a continent bowel procedure. That's no fun.
That prognosis doesn't sound good otherwise.
Right, and your symptoms are better and all that. We fix all the symptom thing. I have a friend that actually works here. I can't tell you who he is because that would be violating his confidences on HIPAA. I didn't take care of him. And he had ulcerative colitis for years. He was on Humira, he was on Remicade, he was on sulfasalazine, he's done the whole 9 yards. He was sick more days than not, and stool, felt horrible, couldn't function with his family. Last semester, he had a permanent stoma put in. He hasn't missed a day of anything since. He scuba dives. He does everything in the world he wants to do. He has no more symptoms. He's off all his meds. He feels great. He says, I'm completely happy. I should have done it 20 years
The
ago.
alternative is not so bad.
Yeah, he says I should have done it 20 years ago. All right, so remember I said it's a multiple procedure, right? So they take here, this is the inflamed stuff, so they take all of this, let's cut it out, okay? Now what happens in your large bowel? What does your large bowel do for you? It absorbs all what comes out of the ileum is liquid. What comes out of after it gets to the large bowel, it's made your stool all solid, and we've absorbed about 1 liter of fluid or 2 liters of fluid a day, at least, through there. So what's going to come, this is now the end point on my colon, right? Temporarily, they brought it up and did a stoma on it. Later, after it healed, we went in. We made a fold here. Here, this is the anus. We made like a loop here. They'll make an artificial opening here and attach this to the anus. To the extent they can control the anal opening, they will have some control of continence, but that stuff that's coming out of there is what consistency? Pure liquid. So your anus, although a valuable and marvelous organ, it is not great at containing all liquids, right? So are you still going to have leakage problems dealing with that? And it gets full and overfilled and dribbling, and there might be all kinds of problems with patients dealing with this. Some patients don't get this, although this is aesthetically, there's no bag on your belly, and you're going to the bathroom like everybody else does. You just have a few things to deal with otherwise, right? It's very common that we're doing this. But a lot of patients will still choose for the abdominal pouch. It's easy to work with, and you can control, and you can change the pouch and empty it, and you know when it's happening. So, all right, post-op. This patient had abdominal surgery. Turn, cough, deep breathe, instead of spirometer. Pain, positioning, relaxation. The nurse's responsibility is to check that stoma. It's going to be covered initially after surgery because we just did abdominal surgery. You have a dressing, right? On the dressing change, you need to, must, should always, you should always document the appearance, the size of that stoma. It's 1 inch, pink, good capillary refill, okay? You need to check the stoma because problems in stomas arise. They pull it to the top and pull some skin around it, so if this swells, does it possibly constrict the perfusion to it? It might get dusky and purple and then ischemic, and that your stomach can fail. Or it might have scarring and keloid issues or huge just structural problems after surgery, and the stoma isn't effective. So the nurse's role is measurement and assessment of that stoma. The patient will be NPO originally right away after surgery, right? Most patients are NPO until their bowel sounds return. Now, is this patient going to have a lot of bowel sounds in here? But you should have them here, right? So the small intestine is all still doing its thing. So bowel sounds come back. The doctor says, okay, let's give him something to eat or drink. At that point, we're going to start having liquids go to your kidneys, but if we start having some residue, then it's going to start coming out here. So at that point, you have to pouch it with a colostomy pouch. Did you do a lot of colostomies in level 1? You gave a nod to it? You did something.
We've done them in the hospital.
Some hospitals.
A few of us have looked at them.
Okay, well, that's okay. You saw them in the skills lab, you talked about them in the skills lab, you looked at it.
Well, one of our STEM patients.
Had a stoma, good. I love it. Did it bust and get all over the place and you had to fix it?
Pretty much all of the patients first semester had ileostomies or colostomies.
Because of where you were, that's awesome. Okay, so that's good. You understand, you know, I love it. So, we need to know lots of things change, right? We have to teach that patient to care for it. Are there some self-image problems with pooping out your belly? You're a 20-year-old girl who's had ulcerative colitis for 5 years and you just had a stoma. Are you worried about psychosocial relationships? Right? Everybody would be, right? I think naturally. And then, so we have all of those issues. We start looking for behaviors. Can they look at the stoma, accept it, talk about it, express an interest in changing it? Because some patients go into denial and take a long time before they can come to terms with dealing with it. So we really have to deal with the psychosocial part of that as well as the physical piece, right? We have to teach them to care for it at home, where to get their supplies, how to get insurance coverage for their supplies. Medications are going to change. Meds are absorbed in different places, right? So if you've got a med that doesn't really work until you get to the bowel that they've been taking, that med probably needs to be off the table now, right? We need to look at what's going on with their meds and how it's going to affect their stool. Can it be completely absorbed if they're getting liquid coming out of here continuously? That's a conversation between the physician and the patient, that the nurse can remind people of it. And then we want to help with any teaching. We're going to help teach things like diet, rest, stress reduction. And we want this patient to know infection signs or complications of their stoma signs so they can report to the doctor. All right, other types of surgeries. A cough pouch. We did the J pouch, it's the continent they now poop through their anus, right? This patient, they'll pull it to the surface, they make a reservoir here, and they just pull a little bitty reservoir, a little bitty, like, ileocecal. They take a little piece of the ileum and pull it through. It's a very nice, clean, neat, and it doesn't continuously drain now. It actually can act like a sphincter, and it'll have a pouch that collects all that liquid, and the patient will put in a catheter through that valve and drain, like a large rubber tip catheter, and drain the liquid stool out a couple times a day, every few hours. Just drain their own, so they don't have to always wear a bag. It's cool too, right? And it's so visible. Got it drained, done, good. Right? Ileostomy is when we bag it, right?
Is there reasons why they wouldn't do this?
Totally up to the physician, the patient, preference, insurance. But, okay, yeah, true. Insurance does something. Totally. And I think the ability of the patient to comply, how worried the patient is about visual imagery. Like if the patient's worried about this on their belly, then we probably do the one that doesn't show as much, and we go the rectal or anal approach, right? But if they don't care, or they're going to be really good at self-care, it's totally up to the physician and the patient. And an ostomy nurse can have a lot of input into this too. The ostomy nurse, you know that that's a whole profession out there, right? Okay. Wound care and ostomy nurse is a huge growing profession. We need tons of them. They help surgeons with ideal placement because of the patient's fat rolls, their body structure, where the bones are, and everything. They can help them ideal placement. So they can have input into that decision too. That's what they're there. All right, so the patient has to go through the whole 9 yards if they actually have the ileostomy. Some bags use skin barriers, some don't. You know, this is used to measure the size of the stoma, so then you transfer it to wherever the barrier is, either here or here, and cut the appropriate size. Should it have a gap around the stoma, or should it be closely aligned to the stoma? Shouldn't overlap it, but right as close as we can get, right? So we measure it, we cut it, we apply it. What is the Caraya paste for?
Skin protected.
This is skin protective. The Caraya paste, if it's oozing and leaking, you can use it to fill in the gaps, help it adhere, and protect the skin. Like a little caulk. It's like caulking up your bathtub. That's right. It actually looks like that till it's yellow and sticky. Let's just move on. I've got some other things to watch. You can watch that on your time. Okay, Crohn's disease. Crohn's disease usually begins 11 to 30. Pre-adolescence, right? 11 to 30, the onset of Crohn's disease. Again, autoimmune. Remember that colitis was continuous. It starts in the rectum and it inflames in a continuous path up your bowel. Crohn's is cobblestone. You'll have a patch in here, you'll have a patch over here, you'll have a patch in the small intestine, a patch in the esophagus. Anywhere in the digestive tract is fair game for Crohn's to attack. Okay? So you have cobblestone, patchy lesions anywhere from mouth to rectum. Less diarrhea, less stools a day, and generally no blood, but still frequent stools. All layers of the bowel are affected. The musculature, not just the mucus and submucous, but into the musculature and the bowel wall. They have bad cramping, a lot of abdominal pain, a lot of abdominal tenderness. This inflammation and irritation, malnutrition, weight loss, vitamin deficiency. Because you've got all these inflamed areas, things are going to bypass and not absorb well. You can see in the picture, that's like a Crohn's cobblestone. It's inflamed and blobby. Looks different than that slight inflammation of the ulcerative colitis. I can't remember. That may be the Crohn's disease colonoscopy. It's something like it. All right. So again, autoimmune and origin, but we think diet and stress exacerbate it, but they aren't the cause. Heredity, genetics, environment, they're all affected, but we don't know what causes it. Crohn's, more common in urban areas. Live in downtown New York City, you're likely to have this. Northern, that's both, right? Men and women equally affected. Finally. All right. Diarrhea. Not 20 a day. They're still going to have 12. I don't want 12 stools a day. Urgency. It's like they have a sense of urgency and cramping and they got to go then. They have to go. Weight loss, malnutrition. Even after they empty their bowel, they feel like they haven't emptied their bowel. And then also colitis, the symptoms are relieved for a few minutes. They go, have a diarrhea stool, get up, and they still feel like they're full and have to go. So they have a persistent feeling. They can get constipation with this disease. Like normally it's diarrhea, but this patient can have all bouts of constipation that can cause complete bowel obstruction, which is also not good. Fever, anorexia, fatigue, delayed growth and development. An 11-year-old who can't absorb their nutrients might have some developmental issues we have to deal with, right? Psychosocial development in pre-adolescence and adolescence. Their Erickson's psychosocial stages might really be affected. Freud's psychosexual stages might be affected.
I have a question. With the multiple diarrheas, is that every single day, or does it come and go?
This disease, both of them exacerbate and flare. So they may have perfectly normal for days or weeks, and then it'll flare, and then they have several days of, yeah. I've seen patients bad enough they have to be hospitalized for a week or so to let their bowel rest and go on CPN. That's bad. That's like the worst of the worst. Most of the time, they can manage it with their medication. And then they may flare, have a couple days of misery, get it to subside, and then go back to their life. But I think I mentioned my friend who has ulcerative colitis. I mean, he was sick more days than not, which pushed him to having surgery. And nothing was helping. He never really came none of it. All right. Barium swallow and barium enema might both be used. Because if they've got cobblestoning in the esophagus, right, that's why we do the swallow. EGD, that's when we go esophago-gastroduodenoscopy. We go through here and look. The colonoscopy, go from here up. We don't actually meet in the middle. We never get past the duodenum here. We never get into the ileum here. Capsule endoscopy, what's that? We swallow the camera. It takes pictures all the way down, and it sends it to a computer where the doctor can get pictures all the way down. What a nice way to do a colonoscopy. CT, CAT scans, and MRIs. And then I think these make sense. Complete blood count. If you're malnourished, you might be anemic. CRP, inflammatory marker, right? Albumin, a protein that you might not be absorbing well enough. Globulin, another protein you might not be absorbing well enough. Transferrin, that's iron. Because of the cobblestoning and the malnutrition, you may not be absorbing enough iron. So, do you think anemia is a problem? Of course. All right. Some meds to suppress the immune response. I'm pretty sure you'll have seen some of these before. Aminosalicylates, aspirin, corticosteroids, Imurin, azathioprine. I talked about that. Even though these are highlighted, I don't think you need to worry about them. Infliximab. We did that in our learning activity, right? Decreases inflammation. Don't worry about this one. I got carried away with my bowling. This is Flagyl. Metronidazole, that's Flagyl. If they have active lesions, we can use it. Okay, non-aggravating foods. So find your triggers, keep your food diary, find your triggers, and don't eat them. Seems like a good idea. Then they want foods that heal tissues. What foods aid in healing? What nutrients? We know protein. What else? Vitamin C, vitamin E, and zinc. All very tied into tissue healing. Vitamin C, vitamin E, and zinc. All right. Surgery here. It can't cure, right? Ulcerative colitis, it can cure. It doesn't cure, but it can help with symptoms. If you've got an area that's really bad or being obstructed or is at risk for something where it all blows up and it opens up. Thank you, preparation. Whatever that word is. I'm having word loss today. Okay. And then we can do surgery for that. So if they developed a fissure where you can see, remember it goes all the way through the bowel wall, right? So you might have an opening where now the bowel is oozing out to another area, opens up into another organ. And so they might have, that's going to cause peritonitis, it's going to cause infection in the other organ. They develop a fissure through the bowel wall to the bladder. And start having stool in your pee and you've got an opening between the two. It's going to take some surgery, right, to remove symptoms. So that's we can use for that, and when we think the inflammation is bad enough, it would perforate or have complications, then we can cut that part out. And that's when we'll reanastomose, right? Because it's not continuous. All right, so our diarrhea. Our priorities are diarrhea, nutrition and coping. You can the mental and emotional coping of this. This is, I don't know, each of these diseases is tragic in its own way, and they have a different emotional impact on the patient. So this is tough. Also, the colitis patients, we have to make sure they're getting screened regularly for cancer, right? They were high risk. Crohn's, not so much. UC is. They either understand their meds, they need to know their triggers. The most common triggers are listed there. And B12 zinc and iron dextran for replacement because there's not absorbing B12 zinc or transferrin iron, right?
So you said the Crohn is less cancer?
Crohn's is not at risk for cancer. UC is. The ulcerative colitis patients are the ones that have a high cancer risk. Doesn't mean Crohn's patients wouldn't ever get colon cancer. They're just not the high risk group. UC is the high risk group.
What about intestinal cancer? I mean, because they're damaging.
That's colorectal, intestinal, yeah.
So they're not at high risk, even though they're damaging all that.
So UC is the one that's more likely to cause cancer. Now, when we do colorectal cancer, there are other risk factors for it, and we'll be talking about them.
So Crohn's, you're not